Okay, I hope you can see me. Hello, my name is Christian Thiede, and I'm very happy to be invited to talk in this forum. Stuart, thank you for the kind introduction. My task now is to talk about standardization projects within the AML MRD Working Party. Usually, the AML MRD, the standardization is something which is by many people regarded as probably less thrilling and less scientific, but nevertheless, and we have seen this from the previous presentation, it's essential to move this technique, MRD detection, from the desk, from the research part into the clinical routine. And I think it's fair. We have seen already some of these data this morning to compare AML with other diseases like CML and ALL, where MRD has already been very successfully applied and implemented into the clinical routine. And there are several reasons why this has been so successful. Among those are, of course, the fact that we have very specific targets, especially in CML, where we're only dealing with one specific fusion gene, which is BCR-ABL. In ALL, we have one group of molecular alterations, which is either the IGVH or the T-cell receptor rearrangements, which are really clonally specific and very stable. Whereas in AML, we have a completely different situation with different translocations, which you have heard of in the previous talks. We have the nucleophosmin 1 mutations and different mutations which characterize the leukemia. These different molecular targets also imply different methodologies which can be applied. In CML, we are dealing with qPCR, in some few instances with digital PCR. In ALL, qPCR or next generation sequencing are used, whereas in AML, we have a variety of different technologies, which of course further hampers the standardization of these different applications. And in addition to that, standardization was taken up very early in the CML field by recognizing that there is an urgent need to do so, to use the method clinically. And this was a very successful program, which led to the a definition of certain cutoffs which are early in clinical use, so the major molecular remission, MR4, 4.5, or MR5, which are well established. The clinical colleagues are used to these due to the frequent publication of guidelines and the clear association with clinical outcome. The same applies to ALL, where cutoff for 10 to the -4 is well defined as defining patients with either high or low risk, whereas similar cutoffs are still lacking, and we've seen this in previous talks by Richard and his colleagues. And I think that's also something which is extremely important to recognize, that having methods to treat patients in specific situations, such as the availability of second or third generation TKIs, or certain treatment options like TKIs or BiTEs in the ALL field, are very important, whereas in AML, this is still lagging behind. So you see from the many question marks we have here that there is a lot to be defined in the field of AML. This is just to sum up again on the different methods which are in use, and the AML MRD Working Party met first about 6 or 7 years ago to trying to standardize the spectrum of methods and how to apply these methods in a more definite way, making the method of MRD detection AML more applicable in patients. And you see the different pros and cons on these methods. We have heard about that before, so I don't want to allude on that in more detail. The focus of my talk will be the molecular methods. So I'm not a flow cytometry person, but flow cytometry, of course, is also a very important method in MRD detection in AML and needs also a lot of standardization, but this will not be my talk's focus. So I will briefly mention what is ELN-DAVID, formerly known as the ELN MRD Working Party of the ELN. What are we doing? What have we done so far? And I will show you briefly two round-robin tests which have been performed under the auspices of the ELN MRD Working Party on different topics in molecular MRD. We recently reconfigured or renamed the ELN MRD Working Party to ELN-DAVID. This name was not chosen by chance, but it was we were intrigued, and it was important to mention the important contribution by David Grimwade, who led this MRD Working Party for 15 or more years, actually introduced many of the activities in this. And it's, I think, important to remember his important work. He was the first actually to perform standardizations here. For example, the WT1 activities he performed, where he compared the accuracy of the methods and compared different methods. And this is one of the papers on WT1 MRD detection, which is most frequently cited. So what is the ELN MRD Working Party now? ELN-DAVID. It's a consortium of people doing MRD. It's chaired now by Michael Heuser. Jacqueline Kloos from Rotterdam is a vice chair, and I have the position as a treasurer, and there are several people involved. The objectives are the scientific exchange and collaboration, education, training. We want to standardize and to perform quality control, and that's something I will allude a little bit more later on. And we want to generate clinical evidence for the different methods for the use of AML MRD. We have subcommittees on the different methods. So flow cytometry is led by Sylvie Freeman from UK and Francesco Buccisano from Rome, qPCR by myself and Richard Dillon, NGS MRD by Peter Falk and Chris Hourigan from the NIH. And there's also a clinical subcommittee which tries to generate clinical evidence, which is led by Constanze Döner and Gail Roberts. The activities which performed led to a first publication. And I think what's important here to mention is nomenclature. So we, of course, think about a lot about standardizing assays, but what we also have to standardize, of course, the wording, the assays, how they are applied, when they are used, which materials are used, what are the intervals. And that was the intention of our first publication, which was published in 2018 and is now frequently recognized as an important contribution to standardizing this. But we realized that this was, although it was a good start, needed an update, and this was the reason why we met already in December 2019 to start to work on the revision of the ELN MRD guidelines. So we had several meetings on that. We generated a first draft, and we performed a Delphi survey where we put in certain statements and voted on these to generate additional evidence. And this was finally then submitted to Blood and more recently published. It has 4 sections, one on flow cytometry, molecular MRD for future improvements and the clinical recommendations. And the rating of the recommendations was done by the level of evidence, the grade of recommendations, and the level of agreement in the Delphi poll. One of the most important aspects there is that frequently you read about positive and negative MRD, and you've seen from previous talks by Richard and his colleagues, Richard Dillon and his colleagues, that this is probably not appropriate anymore. We need thresholds to really deal with that, and we also need kinetics to assess the validity. And we also know that certain positivity is probably not associated with a higher risk of relapse, especially, for example, in the core binding factor leukemias. So we have now a definition of a situation where MRD can be called MRD low level, if a patient is below a certain cutoff, which is 2% for the NPM1 AML MRD and for the co-binding factor leukemias, and 0.1% for flow cytometry and for NGS MRD. This is again relating to the positive and negative, and we should avoid just putting these positive and negative, but putting more evidence on that with respect to the threshold and the values. We defined also that a molecular MRD assessment should reach a sensitivity of 10 to the -3 or lower. qPCR, digital PCR, or error-corrected next-generation sequencing are clearly recommended. We also defined that either EDTA or heparin can be used as anticoagulants for samples for molecular MRD analysis. We also stated that we should not aspirate too much bone marrow, because if you use higher volumes, then this is frequently diluted by peripheral blood. And it's also recommended that you should use the first pull or reposition the needle to generate material for flow MRD especially. And methods for cell isolation should be kept consistent to really avoid any interference with the methods by using different methods for cell enrichment. Whenever we have certain leukemia-specific PCR assays, which is most importantly nucleophosmin 1, the PML-RARA, or the co-binding factor leukemia rearrangements, these should be preferred over less specific markers like WT1 or EVI1 expression. If you perform targeted next generations using leukemia-specific mutations, which are identified at diagnosis, this should be preferred over agnostic panel approaches because it's usually more sensitive and it can be standardized. If a panel approach is used for NGS MRD, whenever you have an emergent variant, this should only be reported if it's confidently detected above the background noise. When NGS MRD is used, it's important not to focus probably on one mutation, but one should focus on all detected mutations to deal with the aspect of clonal evolution. And germline variants, which are usually detected at a variant allele frequency of around 50%, especially in those genes associated with leukemia predisposition, should be avoided for MRD NGS because they are not informative for MRD. If NGS MRD should be performed for targeted, for those target when target genes are used, they should be used for targeted agents. Those molecular markers should be used. Oh, sorry, there is no uniform pipeline so far, and there's an ongoing need for harmonization, and I will come to that in a minute. And cross-sample contamination should be evaluated and controlled for using bioinformatic tools also. Further definitions can be read in the most recent publication on the updated publications, which came out in December last year. Just a few reps from the differences between 2018 and 2021. One is, for example, the molecular relapse, which you have seen before by Richard Dillon. When you have a patient who is MRD negative in a sample and becomes MRD positive in a subsequent follow-up, it should be controlled in a subsequent follow-up with a rapid confirmation. And when the patient shows a further log10 increase, this is called molecular relapse. And if a patient is below the threshold but still positive, this should be called CR with an MRD positive low-level result. Also, the time points when and with what material MRD analysis should be performed were done and were defined in this updated recommendations. For example, as already mentioned before, if you perform NPM1 MRD with qPCR at diagnosis, it should be also assessed after 2 cycles of chemotherapy, induction chemotherapy. And if the patient is positive in the peripheral blood, this is predictive for poor outcome, as mentioned before, and potentially this patient can go on to an allotransplantation. However, after end of treatment, bone marrow should be assessed because it's more sensitive, and during follow-up, follow-up should be performed at least for the first 24 months in regular intervals, 3 months for the bone marrow or 4 to 6 weeks from peripheral blood due to the lower sensitivity. And the same is defined for other sub-entities like the core binding factor leukemias or the APL. And only if the patient is not positive for any of these alterations, flow cytometry should be performed as the regular method for MRD assessment, or can be further substituted by, for example, next generation MRD. These MRD recommendations are now available also via the ELN-DAVID webpage, which was recently launched. And if you want to be updated on the activities of this group, please feel free to have a look at these at this site. And we are constantly increasing the number of links there. We are also planning to have educational videos posted there. And I think this is an important activity to standardize AML MRD detection. Just briefly to projects which performed to really have a wet lab standardization. We performed a round-robin test for NPM1 qPCR, which was led by myself and published at EHA 2020, and first round-robin for NGS MRD was performed by Michael Heuser, and the data were shown on the EHA 2021. Just briefly, the data for the NPM1 MRD, and I think we will see more of that in the subsequent talk by Stuart Scott. We distributed tenfold dilutions of the OCAML3 cell line in normal white blood cells. We distributed cDNA and RNA materials to 19 laboratories in Europe and the United States in 10 different countries. And in addition, we also distributed 4 wild-type samples. And you can see here the results which were sent back to us. These are the RNA results. Uncorrected means the data are just as the labs reported them. And you can see that there is a nice log reduction, but also at the same time, there's a considerable variability of the results of more than 2 or up to 3 log 10 levels. There are some outliers which were there, but the majority of the labs were around 2-fold, 2 log 10 levels. We also distributed standards to the labs, and if the labs used these standards, the results were a little bit closer. But you can see that the closest correlation was actually seen when the labs were reporting the log reduction based on their own results. So here, quite consistent data were shown down to a 4- to 5-fold log dilution. Something which is probably more concerning is, or making us more concerning, is the fact that there were a number of false negative, but also false positive results. So about 11% of the labs and 16% based on the RNA samples actually reported false negative results for the lowest samples. And a quarter of the labs based on RNA and almost half of the labs based on cDNA actually reported NPM1 levels in any of the 4 wild-type samples which were distributed. Luckily enough, the majority of them actually reported them at very low levels, so below 0.01% NPM1-able, but still, of course, this is something which is concerning and needs more work, and I think that's something Stuart Scott will allude on. Only only 1/3 of the participants actually provided completely correct results. Another study which actually was performed by Michael Heuser is a first study on how we could potentially standardize the work using NGS MRD. So they distributed 20 samples to 13 labs participating in this study, and the labs were asked either to detect these alterations known to be in these samples or reported to be in there, either by their individual protocol or by a central protocol, including central bioinformatics. And these are the alterations which were tested in this round robin. The variant frequency ranged from 1.55 to 0.004%. And these are the two different methods. So either the labs perform their own sequencing approach or the central sequencing approach, which actually based on a procedure, an error-corrected procedure, which Michael Heuser's group published in 2018. And here you can see some of the results. I cannot go into too much detail due to time constraints, but what you can see here is that the variability of the coverage is quite high, although there was a decent coverage for the majority of alterations between 10 to the 5 to 10 to the 6 reads. The coverage is much more consistent between the individual laboratories when the central method is used. The same is true for the limit of detection, which is for the individual methods in the range of 0.1% and almost 1 log 10 lower, 0.01% if the central method was used. The same is true for the repeatability, which is consistently better using the central method. The linearity, for example, for the IDH1 mutation or the nucleophosmin-1 mutation for the dilution, and the overall correctness of the results is much more consistent if the central method is used, potentially indicating that if we are using or agreeing on a certain protocol for performing NGS MRD, we might be already in a situation where this method can be used in a very standardized way. So to sum up, I think we all are aware of the importance of AML MRD detection, but we also have to focus on the fact that standardization is essential for clinical use. The methods which are currently used and the data interpretation is still highly variable, but we can see that we could achieve higher concordance if we imply certain means of standardization. And this is an ongoing activity of the ELN-DAVID consortium to optimize, especially the molecular, but also, of course, the flow cytometry methods to make MRD detectable or applicable in the AML field. And with that, I'd like to thank again all the people involved in the ELN-DAVID consortium, and anyone who's listening today is kindly invited to be part of this activity. Of course, the more people are involved, the better we can achieve this goal. And with that, I'd like to thank you for your attention, and I'm happy to take questions.